Good afternoon, everybody. I'll run through these slides quickly. Subclinical hypothyroidism, the diagnosis, the definition depends upon the age. A serum TSH, it basically means a serum TSH level above the upper limit of the reference range in the presence of normal concentration of T4 or free T4. In the neonatal period, it would mean a TSH of 6 to 20 milli-IU per liter, and after the neonatal period, the TSH level is 4.5 to 10. So the mild congenital hypothyroidism in the neonate, I'll first talk about the newborns, could be transient or permanent, and there are certain categories that are at high risk, like preterm or ill neonates, small for gestational age, those conceived through IVF and multiple pregnancies, and there are certain precautions or certain steps that we need to take in such babies. So in such children, we need to do a second neonatal screening, and when should it be done? It should be around 2 weeks of age, or 2 weeks from the first screening test. And in whom should it be done? In those at risk that I just mentioned, and also in children with chromosomal abnormalities like Down syndrome, malformations, steroid treatment during pregnancy or neonatal period, and maternal thyroid dysfunction, especially autoimmune thyroid dysfunction in the mother. So a little bit, I'll spend a little time talking about maternal autoimmune thyroid dysfunction. We all know that thyroid receptor antibodies are IgG antibodies, and they can cross the placenta. They can either stimulate, causing neonatal graves, or block, causing hypothyroidism. Now a little bit about blocking TSH receptor antibodies, which cross the placenta and account for 2% of cases of congenital hypothyroidism in North America. We do not have the statistics in India. It is transient because IgG antibodies are cleared from the circulation in 3 to 4 months. However, treatment would be needed in some cases if the TSH remains greater than 5 after the age of about 4 weeks. TSH newborn blood for the antibodies needs to be done. We need to test the neonatal blood for the antibodies if there is a history of autoimmune maternal thyroid disease or previous sibling affected with transient congenital hypothyroidism. So it's very important to take a detailed history in any child with subclinical neonatal hypothyroidism. So, and another thing is, we have all encountered the situation wherein on ultrasound you see a normal thyroid gland, but on scintigraphy it's reported as absent, and that could be because of the blocking antibodies. Prematurity and low birth weight babies are also at risk for thyroid dysfunction due to several reasons, including immaturity of the hypothalamo-pituitary thyroid axis. They are deprived of the transplacental iodine as well as T4 because of a shorter duration of gestation. They are prone to sick thyroid syndrome and several other factors. And they present with a myriad of thyroid dysfunction, which could range from frank congenital hypothyroidism to subclinical hypothyroidism, hypothyroxanemia, etc. It's usually transient, and we need to monitor them and repeat the thyroid function tests. So, impact of persistent subclinical hypothyroidism and developmental outcome not adequately investigated, as has been the hypothyroxanemia, that has been more extensively investigated in this category of patients. So thyroid function should be monitored in such cases. So monitoring, these are the guidelines. There are 2 sets. One is the ISPAE guidelines, which recommends second screening at 2 weeks and an additional screening at 4 to 6 weeks in cases of severe prematurity, VL, very low birth weight children, and critically ill neonates. And there is another group that has come out with certain other guidelines more recently. So incidence of congenital hypothyroidism with eutopic thyroid gland is double in twins compared to singleton, and it's even higher in multiple pregnancy. One peculiar characteristic of twins, as happens in also premature, the same thing, they can show a delayed TSH rise, and that's the reason why we need to rescreen in this group of children as well. So in vitro fertilization, now we are seeing more and more children who are conceived through IVF, and these children have subclinical hypothyroidism not only in the neonatal period, but also when they are older, at around 4 to 14 years, studies have shown that. It's believed to be due to an epigenetic developmental abnormality in the set point of TSH sensitivity related to pre-implantation manipulation of the embryo. So currently there's no clear guidelines about this, but we need to keep this in mind when we are dealing with IVF children. So certain gene mutations, have been found to be the cause of the so-called sporadic congenital hypothyroidism, and these could also give us a picture suggestive of subclinical hypothyroidism, especially the TSHR receptor gene mutation. Biallelic causes severe complete TSH resistance and severe hypothyroidism, and this could manifest as a delayed rise in TSH. So we need to keep that in mind when there is a family history of congenital hypothyroidism. In the newborn screening, it can be missed, but later there can be a delayed rise. Monoallelic can be a partial TSH and manifest as subclinical. So is the DUOX2 gene mutation, which presents as a goiter usually, whereas the TSH receptor gene mutation, they do not have goiter. I will not get into these in detail for want of time. So management of neonatal subclinical hypothyroidism, the optimum management is still debated. In a well child with subclinical hypothyroidism, that is a TSH between 6 to 20 as per the ISPAE guideline, for more than 3 to 4 weeks, we have the option to either start the levothyroxine supplementation after discussing with the family or retesting 2 weeks later without treatment. In particular, the TSH is a little on the lower side. In special at-risk categories, like we had outlined before, they need to be monitored even more carefully. Now, coming to subclinical hypothyroidism in children, which is defined as a TSH between 4.5 to 10, mild hypothyroidism, which is mild, it resolves spontaneously, frequently, and may persist without progressing to overt hypothyroidism. Of course, we can't have a blanket statement like this because it depends upon the etiology also. Hashimoto's thyroiditis and subclinical hypothyroidism, it is one of the most frequent causes, and it's also common in genetic conditions, and the risk for deterioration is very high. About 50% of them progress. We all know that obesity is associated with marginally increased TSH. About 70 to 23% of overweight and obese children have mild increase in TSH level. It is believed to be due to leptin-mediated production of pro-TRH, and autoimmune thyroiditis is seldom the cause. It's reversible with weight loss, and treatment is unnecessary. There are certain genetic syndrome associated with subclinical hypothyroidism, like Down syndrome, which is associated with the whole spectrum of thyroid abnormalities, and pseudo-hypoparathyroidism type 1A can also manifest with subclinical hypothyroidism in addition to multiple hormone resistance. Now, in Down syndrome, which is, this is something recently, in one of the recent studies by Soonawala et al., the treatment of subclinical hypothyroidism the first 2 years, it has been shown to lead to an improvement in the hypothalamo-pituitary axis set point in children with Down syndrome and reduce the risk of future autoimmune hypothyroidism in this category. How do I change it? Yeah. So iodine deficiency and excess, this is just theoretical as far as I'm concerned, because we don't have facilities to do urinary iodide test in India. I have been looking around for it, but unfortunately there's nowhere it's been done. That's what I have been given to understand. So iodine deficiency and excess can both cause subclinical hypothyroidism. Iodine containing medications like amiodarone as well. Interferon alpha is used in the treatment of hepatitis C, and that has been associated with myriad of thyroid dysfunction, as are children who are on anti-epileptic drugs. They too demonstrate thyroid dysfunction. There's been a lot of studies on environmental endocrine disruptors in a variety of things, including environmental estrogens and estrogenic, as well as disruptors of multiple endocrine hormones. So those can also be associated with subclinical hypothyroidism. Now, approach to management of subclinical hypothyroidism is a detailed history. If there has been a history of neonatal hyperthyrotropinemia, a transient neonatal hyperthyrotropinemia, this could be a pointer towards one of the genetic forms of, mild genetic forms of congenital hypothyroidism that we just discussed. Or we need to ask for a history of autoimmune or genetic condition. If the child has other autoimmune conditions like alopecia or celiac disease or type 1 diabetes, we need to ask a history of any medications that are known to interfere with thyroid dysfunction, and endemic iodine deficiency. I'm not quite clear how to approach this because we have no way of confirming this. We need to take a detailed family history of subclinical hypothyroidism, goiter, endocrine, genetic, and autoimmune diseases. Physical examination should be detailed. And if the TSH is between 4.5 to 10, we need to first rule out abnormal values caused by maybe a laboratory problem or a diurnal variation or transient causes, whether the child is recovering from some illness. And then we need to reevaluate. There's no need to start treatment right away. We need to reevaluate at 4 to 12 weeks after the first test. So it's 1 to 3 months later is the second test that needs to be done. And if the TSH is persistently elevated, then a diagnostic workup is recommended. Now, what is a diagnostic workup? These are the investigations. We should do thyroid antibodies. At the second test that we do 1 to 3 months later, we could do an ultrasound because sometimes the thyroid antibodies could be negative, but it still could show some feature suggestive of Hashimoto's. And based on whatever is the history, physical and dysmorphic features, we might have to investigate further. Now, like I said, urinary iodine excretion is more of a theoretical point that I have put here. And if there is a history of hypothyroidism, like consanguinity and hypothyroidism recurring in siblings and early onset hypothyroidism, negative autoimmunity, then we may want to do genetic analysis because we know that autoimmune hypothyroidism generally starts a little later after the age of 5 years. And this is a recent point, like if there is mild subclinical hypothyroidism and there are risk factors such as a family history of hyperlipidemia, acanthosis, BMI, we need to do a screening lipid panel. I'll just, this is what the algorithm is. It's there in the references that I have shared with you for subclinical hypothyroidism in older children. And the treatment, I think somebody was taking a picture. You want to take a picture? Okay. So now I would like to share this 2019 article. When a replacement hormonal treatment might be advisable, this has given me also a few points what would predict the evolution of thyroid status. You mean the deterioration. It's a baseline TSH values. It is one of the most powerful predictor of evolution of subclinical hypothyroidism over time. If the baseline TSH is over 10, then we do need to beware that this could progress. And then what are the pathological repercussions of prolonged subclinical hypothyroidism? Studies have shown that a cluster of subtle metabolic and proatherogenic abnormalities, such as increased visceral adiposity, slight alteration in lipid profile, and homocysteine levels, have been seen in untreated children with long-standing subclinical hypothyroidism. Triglyceride HDL cholesterol ratio has been recently proposed in pediatric age group as an index in the prediction of increased arterial stiffness, and therefore in selection of children requiring an intervention to prevent atherosclerosis. So this is something we may want to consider doing in our children with subclinical hypothyroidism who have a strong family history. So in those cases which exhibit during follow-up a deterioration of atherogenic risk profile, a 2-year treatment with levothyroxine might be suitable in order to prevent coronary vascular disease in adulthood. So subclinical hypothyroidism is not as benign as we thought earlier. We need to dig a little more into that. The other possible, so this is what I just covered. Oh, there's one more point I think I missed. Yeah, another point is that Hashimoto's thyroiditis, several studies have shown, which I have, unfortunately, I don't think I put it in the slide. Hashimoto's thyroiditis is known to be associated with papillary cancer, and children with Hashimoto's thyroiditis who have elevated subclinical hypothyroidism need to be treated, not only because it will keep the size of the thyroid gland in check, but also it may reduce the risk of future thyroid cancers as well. So this has been another recent study, the information which I would like to share with you. I think I would conclude with this slide on idiopathic and mild subclinical hypothyroidism. Most of the points I have gone through already. Thank you.